Hi everyone, my name is Aria Fallah. I'm an assistant professor here at UCLA in the Department of Neurosurgery, and I'm a pediatric neurosurgeon at Ronald Reagan UCLA Medical Center, as well as Mattel Children's Hospital here at UCLA. And it's my great pleasure to be here today and talk to you about a modern and comprehensive approach to pediatric epilepsy surgery. I welcome you to ask any questions you have on Twitter using the hashtag, as you see on your screen, hashtag UCLAMDChat. And I look forward to answering some of these questions at the end of this webinar. So the first question that's relevant to this talk is, what is a seizure? And seizures, I'm sure some of you have family members or children that are affected by seizures, and others may have seen this on TV, but it can be quite a scary event. And what makes it really scary is that seizures are usually unpredictable and they're sudden, and it involves usually a process that takes between a few seconds to maybe a few minutes, where there's abnormal movement of the arms or legs. And sometimes seizures can present more subtly, where a patient just blanks off, stares off blankly for a few moments before they come back. And sometimes seizures involve a loss in consciousness, and other times they don't. And this can be quite scary for many parents for the first time they see their child have a seizure. So a seizure by itself does not mean that you have epilepsy. There's many different reasons why children may get seizures. A very common seizure that children get are called febrile seizures, and these are seizures associated with a sudden rise in the body temperature, and that's called a febrile seizure. Now, when you get the diagnosis of epilepsy, this implies something else. So epilepsy occurs when you've had 2 or more seizures that have been unprovoked, and this is when you start seeing a pattern of repetitive seizures. And at this point, usually the first time you have a seizure, the best thing to do is bring your child to the emergency department and have your child evaluated. And in certain instances, there's reason to do further testing in the form of an EEG or an MRI. But when you have epilepsy at this stage, you really must be seeing the neurologist at this stage, the pediatric neurologist that specializes in this. And the topic of today's talk is about epilepsy, and specifically the type of epilepsy that does not respond to medication. So what is the impact of epilepsy on children? So epilepsy is very prevalent worldwide. There's over 10 million children across the world that are affected by epilepsy, and it's actually a little bit more common. It's twice as common in developing countries compared to developed countries. But even that, in developed countries, we have 50 per 100,000 children that are affected by epilepsy. And epilepsy is more than just seizures. So epilepsy is commonly also associated with learning disabilities, with developmental delays. It can affect cognition. It can cause behavioral difficulties. It can cause psychosocial problems in children. So it's just much more than just having seizures. There's a landmark paper that came out in the New England Journal of Medicine in the year 2000 that looked at a large population of people that have untreated epilepsy. And they saw how often were they able to control the epilepsy with one anti-seizure medication. So when they gave people one anti-seizure medication, 47% of the seizures stopped. So in 47% of people, they had no more seizures. So that leaves the rest of them still having seizures. So now they went, and when they added a second medication, only another 13% responded. So still there's a large majority there's a significant number of people that still have ongoing seizures. And with each added medication, the third medication that was added, only 4% more of the people became seizure-free. And this is a trend that we know. So the more medications you try, the less likely you are to achieve seizure freedom. So if you haven't achieved seizure freedom by your second medication, the chances of you trying more medications is very low in being able to control your seizures. So this is a very important concept that guides a lot of the decision making that clinicians make around epilepsy care. The other thing that this article found was that patients that have a structural lesion in the brain, something that is physically different or abnormal, have a much higher probability of not responding to medications than children that have normal appearing MRI scans. So this becomes important because if we see an abnormality on the MRI, we know offhand that your chances of seizure freedom with just medication alone is much less than the rest of the population. Now, I just want to take a minute just to emphasize what is so different about children compared to adults, and why is the comprehensive care of children with epilepsy particularly challenging. And there are several reasons why. Because it requires very specialized knowledge, required both in the medical aspects and the surgical aspects of management. Here at UCLA, we're very lucky. We're probably one of the centers one of the top centers in the world that has one of the largest experiences with epilepsy surgery, and specifically pediatric epilepsy surgery. We have a lot of the world experts that work here at UCLA, and we've done over 800 surgical cases of epilepsy in children. So that cumulative experience and knowledge becomes key, because as you will find throughout the rest of the talk, that each child affected by epilepsy manifests very differently. And it's very important to be able to identify those differences in children, because management is very different. You also need a well-coordinated collaborative relationship with a multidisciplinary team. So it's a large team of many, many doctors that work together for the management of children with epilepsy. And today, many epilepsy centers are being designed and organized with this collaboration in mind, so similar to what we have here at Mattel Children's Hospital at UCLA. Now, why is pediatric epilepsy any different from adult epilepsy? Is there a difference? There is a huge difference between pediatric epilepsy and adult epilepsy. Some of the reasons I've highlighted here. So there's critical differences. First, the diversity of disorders. Children, the way epilepsy manifests in children is in many more different ways than adults. The underlying substrate that causes epilepsy in children is much different than adults, and there's quite a few more of them than they are in adults. Their EEG patterns are very different, and they require specialized pediatric epileptologists to interpret their EEG as opposed to adult epileptologists. Their semiology can also be very different. What I mean by semiology is the manifestation of their seizures. Children can manifest their seizures very differently than adults. And lastly, there's different concerns when it comes to children. We're talking about a developing and growing brain. So the decisions that we make really are to prevent any psychosocial and developmental deficits that may result as a consequence of untreated epilepsy. There's additional considerations. So patient selection criteria is very different. So quite often, one of the things we think about is the harmful effects of anti-seizure medications in children. And so sometimes we consider surgery a lot more quickly than we may do in adults. Our pre-surgical assessment methods are different. So kids cannot undergo some of the tests that adults can go. They may not be cooperative for some of the testing, and some of the testing is unique to children. The surgical indications are different. There's one of the important things that I'll talk about is in children, it is extremely, extremely important to be evaluated by a pediatric epileptologist, because there's many conditions that can mimic seizures that may actually not be seizures in children. And there's conditions that do not respond well to surgery. There's also conditions, there's actual epilepsy in children, some of which that actually may resolve with time, and there's no reason to intervene. So it becomes extremely important for the child to be seen at a center that specializes in pediatric epilepsy. The timing of surgery can be very different. Some of these operations that we do in children, we try to take advantage of the fact that their brain is plastic, which means their brain can take over new function. So, and we know the younger the child is, the greater the brain's ability to do that. So timing of surgery becomes more critical than when you're considering adult surgery. And the surgical techniques are very different. The operations that we do in children are vastly different. We do operations where we remove an entire hemisphere of the brain, an entire half of a brain, or we do large resections in children that quite often or rarely ever do in adults. So the types of operations require very specialized training and expertise to be able to do this in any child safely. So this topic of surgery for curing seizures, and what I want to emphasize here, what we're talking about is children that we call medically intractable to epilepsy. So, so despite medical treatment, they continue to have seizures. So, so nature has it that some of the patients that are most difficult to treat medically may actually be some of the best surgical candidates. So although the idea of surgery really scares a lot of children, a lot of families, and actually even a lot of doctors, it shouldn't be that way, because here is a tool that has actually been around for a very long time. It's been around for over 100 years. And there's actually a knowledge gap, even in the medical community, between, you know, from some doctors, some maybe pediatricians or pediatric neurologists who don't specialize in epilepsy, and they think surgery is very dangerous, and it's something that should not be considered. So there, in the community, there's sometimes instances where parents are being told that your child is very difficult to treat epilepsy, and they will just continue to have seizures all their life. Even though that may be the case, that conclusion should not be made until the child is fully evaluated by a specialized center to make sure that this is not the type of epilepsy that we can actually cure with surgery. So, and then the other side note here is that the amount of epilepsy surgery we're doing is very little compared to the actual population that we think could actually benefit from surgery. So there's a little gap that has been created between children that can benefit from surgery and the actual number of children that we are helping with surgery. So other reasons why brain surgery should be considered for children is that seizure medication can have harmful effects on the developing brain. So seizure medications can have side effects. Seizure medications can make the child more drowsy or sleepy or weak and not be able to interact and play and learn like the other children. So this is very different in the adult brain, where the development is complete. In children, as their brain is growing and developing, we know that seizure medications, even though they help with the seizures, may be harmful to the growing brain. The second issue, which I talked about previously, is that there's functional plasticity of the developing brain. And what do I mean by functional plasticity? That means that if a child is young enough, if we remove a certain part of the brain that carries a certain function, let's say a motor function, the other areas of the brain can actually compensate and take over this function. So the younger you are, the greater the brain's ability to take over function that is lost by another part of the brain. And this doesn't happen in adults that have a certain portion of their brain removed. Function in adults is a lot more static, so we don't acquire new function. We'll just lose it by removing that area of the brain. There's also psychosocial factors. So seizures really affect children in their development and their ability to play and make friends and go to school and learn. And the other thing that we know with seizures is even if you have abnormal brain signals between your seizures, that can really affect the child's ability to learn and consolidate new information. So a lot of research is being done regarding the harmful effects of seizures in children. So what are the goals of epilepsy surgery? Whenever we do any operation, particularly when we do brain surgery, we want to know what our goals of an operation are to make sure we achieve those goals, and the family and the child, in certain cases, they all understand what we're trying to achieve. So number one is to control or lessen the seizures. Number two is to prevent the possible harmful consequences of seizures. So in seizures in certain times can actually become a medical emergency if they're prolonged and they don't stop. And in some cases, they can actually be linked to early death. So so seizures are harmful. We're trying to stop them with surgery. We also want to prevent further cognitive, behavioral, and psychosocial problems in children. And lastly, we want to avoid the side effects of medication. So whenever a child gets considered for surgery, there's a large list of technology available to us to be able to properly investigate the child, to really try to figure out where the seizures are coming from. Now this, before we do any fancy tests or imaging, the most important thing is the neurologist who will sit down with your child and evaluate with you and try to get a sense of what the seizure manifests like. What is the particular seizure that your child is having, because that can give us great clues as to where the seizure may be coming from in the brain. So it's a bit like Sherlock Holmes, where we have to figure out exactly where in the brain these seizures are coming from. That's the number one goal. And also to make sure that these are in fact seizures and they're not something that mimic seizures. That also involves a physical and neurological examination. It also involves an EEG. An EEG is it's a test that reads the brain waves. It's similar to an EKG that reads the waves of the heart, the electrical output of the heart. EEG measures the electrical output of the brain, and that can give us clues as to which areas of the brain are abnormal. There's tests like magnetoencephalography, which can pinpoint where epileptic discharges are coming from the brain. 3D spike source localization gives us a very similar type of information. You need to have specialized MRI testing, high resolution MRI, and sometimes you can see abnormalities on the brain that can be very subtle. Again, this is something that's very important because you need a specialized neuroradiologist to be able to read these MRIs that we do in children, because these findings can be extremely, extremely subtle. So you need a person or to be treated at a center that sees a lot of children with this disorder, because that can be very important. We also have functional imaging tests that we can do to figure out what areas of the brain can have what function. So where the speech center of the brain is, where the motor cortex of the brain is, and that is useful with we can do that with an fMRI test. And we also have a PET scan that we do quite commonly here in UCLA, and in fact in all the children that are being evaluated for epilepsy, and that can show us regions of the brain that appear functionally abnormal. So they may be structurally normal, but functionally abnormal, and that can be equally as important because those can also be areas of the brain that are causing the seizures. We also have additional invasive tests. So that's not part of the initial evaluation, but if the child moves on to a second stage of an operation, which I'm going to talk about a little bit later on, we can have invasive monitoring of the brain and try to better pinpoint where exactly the seizures are coming from. So there's several questions that are important whenever we consider the pre-surgical evaluation. Number one, does your child truly have epilepsy? There's conditions called pseudo-seizures where it has the appearance of a seizure, but it's actually not a seizure. There's vasovagal responses where children faint, or they have tics that can appear like seizures. So there's many conditions in children that can appear like seizures, and the most important thing is, does your child truly have epilepsy? If your child does not have epilepsy, none the medications will work, and surgery should certainly not even be entertained. So that's the most important thing. Now, is epilepsy surgery warranted for the given seizure type or epilepsy syndrome? Now, specialized centers, they can tell you there's certain seizure types or syndromes that do not respond to surgery. Certain metabolic disorders don't respond to surgery. There's certain conditions that actually have epilepsy, but they're benign epilepsies where that means that as a child gets older, the seizures will stop. So it's very important to be able to recognize these syndromes because that can really alter the management that you suggest for that child. What is the underlying cause of the epilepsy? That's important because epilepsy can be caused by abnormal development of the brain. It can be caused by tumors in the brain. It can be caused by infections in the brain. It can be caused by vascular malformations in the brain. So there's many underlying causes of epilepsy. Again, this is something that's very particular to children. So it's really important to try to figure out what the cause of the epilepsy is because, again, that can tell us whether surgery is even an option or not, and if it is, what type of surgery may be best. The next question is the epilepsy truly refractory, or are there therapies indicated before considering surgery? So sometimes when the children get evaluated by our epileptologists, they realize that the medication that the child was on was not particularly the best medication to try to treat this type of epilepsy. So it actually may be worth trying another medication, or there's other treatment options that we can available to us that we can consider before going to surgery. So these are things that are really important, again, to be evaluated for at a specialized pediatric epilepsy center. What is the possibility of remission? So these are questions, so not only remission just with medication itself, but also what is the possibility of remission of your seizures with surgery? So these are questions that you should be asking your pediatric epilepsy surgeon. What are the chances of seizure freedom if we undergo an operation? And lastly, and this is quite important, is how prepared the child and the family for surgery. So this is it's a big deal. Having brain surgery in your child, especially for epilepsy, takes a significant toll on your family and your child. So being ready for it, knowing what to expect, how long you're going to be in the hospital, what things can happen while you're in the hospital, the duration of surgery, what will your child experience during surgery. So these are all questions that should be asked because not only the child but the family have to be ready whenever we consider anyone for these types of operations. So I'm going to briefly go over some of the potential lesions that can cause epilepsy. And one of the most common lesion in children are developmental lesions called cortical dysplasia. So this is the abnormal architecture of the brain. These can actually be quite subtle and very difficult to pick up. But this is actually the most common cause of epilepsy that is treated with surgery in children. Hamartomas and heterotopias are also developmental lesions. So hamartomas are areas of the brain that have abnormally grown more than usual, but these are not tumors, they're just overgrown. And heterotopias are normal areas of the brain in abnormal locations. So these can be quite common. Tumors can be quite common in children. So low-grade tumors, gangliomas, or what we call DNETs, these are tumors that are actually very common in childhood, and they're associated with a high incidence of epilepsy. And sometimes what is required is not only just removing the tumor, but there's also areas surrounding the tumor that can cause epilepsy. So it's really important, again, to be when the problem is epilepsy, it's really important to be evaluated by an epilepsy center, because if you go to a surgeon who would just remove the tumor, in certain cases the epilepsy may not stop as well. So you need to have an epilepsy operation sometimes as opposed to a tumor operation. So that's a very important distinction. So vascular lesions, arteriovenous malformations, or an abnormal tangle of blood vessels in the brain, these can cause epilepsy. Cavernous malformations are a very similar entity. These can cause epilepsy as well. Injury to the brain, so strokes, which are actually quite common in the neonatal period. Trauma to the brain, these can cause scarring and also cause epilepsy. And also infectious lesions. These are less commonly seen by us, but these can also cause epilepsy. There's also very specific disorders that are considered for surgery. As we talked about, cortical dysplasia is a common reason to consider surgery. Tuberous sclerosis complex is a challenging situation many of the times, but these children can do quite well with surgery as well. Polymicrogyria is a condition where the brain again is abnormally formed, and that can cause seizures. Hemispheric syndrome, so syndromes like Sturge-Weber, Rasmussen's, these are syndromes that usually affect one entire half of the brain, and the operation for this is a quite radical operation called a hemispherectomy, where an entire half of the brain is either removed or disconnected. But these operations are very efficacious, and over 80% seizure freedom rate following these operations. And we know these conditions don't really respond well to medication. So these are conditions where we would consider your child quite early on to be a surgical candidate. Tumors, as we talked about, and stroke as well can cause seizures that would be able to help with surgery. So the phase 1 evaluation for epilepsy surgery is the pre-surgical evaluation, and this involves, it's a non-invasive phase, and by non-invasive I mean there's no cutting that needs to take place. There's no surgery involved here. Many of the children already have had a scalp EEG, but when they come in, they get a 24-hour video EEG. So that means for the entire duration of their hospital stay, they have these electrodes that are stuck on to the surface of the head in a predetermined fashion, and there's a video camera that's specifically watching your child 24 hours a day. And at this stage, we actually want your child to have seizures, because while your child has seizures, that shows us not only the manifestation of the seizures and what they look like, but also the electrical abnormality of the brain. And we sit there with our neurologist, and we try to figure out where exactly these seizures are coming from. So that's a very important phase of this evaluation. You also get a specialized MRI with very specific sequences to look for abnormalities that may cause epilepsy in children. Neuropsychological assessment is also very important whenever we consider surgery. Now, if the child is too young, we can't possibly do a neuropsychological evaluation, but in many children we're able to evaluate them, and this gives us important information not only to see what the current deficits are, but also try to predict what the consequences of surgery would be. Would we predict a high likelihood or a low likelihood of a new deficit? A PET scan is also standard here at UCLA, and this, like I talked about before, tells us areas of the brain that are functionally abnormal. So even though they may be structurally normal, they're functionally abnormal, and they can, they can also cause epilepsy as well. So once all this evaluation is complete, we have an epilepsy conference, and we have here at UCLA, we meet twice a week with our entire team, and our entire team is made up of epileptologists, epilepsy surgeons, neuroradiologists, neuropsychologists, neurophysiologists, and nurse practitioners. So it's quite a big team, and we have a conference, and we discuss every single child that gets evaluated. And we put our minds together and to try to really figure out, is this child a good candidate for epilepsy surgery or not? And that's a very important conference. And that kind of guides the future direction of care once the phase 1 evaluation is complete. And these are the 3 results that can come out from an epilepsy conference. So number 1 is we may think that the child is not a surgical candidate. And these are situations where the seizures are coming from multiple areas of the brain, or we can't localize where the seizures are coming from, or the seizures are coming from a location of the brain that is eloquent. And I'll talk about eloquence a little bit later on. By eloquent areas of the brain, I mean areas of the brain that carry a certain important function of the brain that we cannot safely remove. So a big goal of us doing epilepsy surgery is to make sure that we improve the quality of life. And you know, if treating the seizures requires us, giving a child a major permanent deficit, in many cases that may not be the right solution, and we haven't really helped the child. So that's really important. So curing the seizures, but at the same time we want to preserve neurological function as much as we can. So now if a child is not a surgical candidate, and by a surgical candidate I mean a resective surgery, so a surgery where we try to cure the patient of epilepsy, they still can actually be considered for some of our palliative treatment options. And palliative treatment options are geared towards reducing the intensity and frequency of seizures. And I'll talk about that a little bit later on. Now, sometimes the data is not great enough for us to proceed to surgery, so we would require an invasive evaluation. And I'll talk about situations where an invasive evaluation may be indicated. And with invasive evaluation, I really mean putting electrodes into specific areas of the brain to try to pinpoint where these seizures are coming from. And lastly, sometimes the evidence just from a phase 1 evaluation is so great, and we are so confident that we know exactly where these seizures are coming from, and it's safe to remove this area of the brain, that we will proceed straight into suggesting that this child or your child being a surgical candidate. So that is a third option. So an invasive evaluation, which I'll talk about in the next few slides, is what we call the phase 2 of this evaluation. And as you can see here, it requires an opening into the skull where we put electrodes on the brain to try to map out exactly where in the brain the seizures are coming from. So the brain, a lot of times, can actually appear normal. So looking at the brain doesn't tell us what areas are abnormal. So we have to record the electrical activity of the brain. And at the same time, we can also map out functional areas of the brain. So the letter M that you see on the screen, that's the motor cortex. So that's an area that we try to avoid resecting. But it's important for us to figure out where the location of that is. Again, these things are not labeled in the brain, so the brain actually appears the same everywhere. So, and then the S that you see behind it, that's the sensory area of the brain. So sometimes it may be reasonable to remove a sensory portion of the brain in order to achieve seizure freedom, because the deficits associated with sensation are usually less than the deficits associated with motor. There's 3 main indications for an invasive EEG. So number 1 is inconclusive preoperative data. So here's an MRI of a normal appearing brain. So even though we have evidence and we have reason to believe that the seizures are focal, and by focal I mean they're coming from one particular area of the brain, we can't exactly tell where they're coming from in the brain, but we have suspicion that it's coming from one specific area. So in these cases, sometimes we can proceed to an invasive evaluation where we test our hypothesis of where we think the seizures are coming from, and sometimes this can lead to a child with a normal appearing MRI to be a surgical candidate. The second situation is when everything doesn't add up, so we have divergent preoperative data. So maybe several of the tests suggest that the seizures are coming from a certain area of the brain, while one of the other tests, or a couple others, suggest somewhere else. So here again, we can use invasive EEG evaluation to really try to pinpoint exactly which one of these hypotheses are true. And if we were trying to predict which of these areas are causing the seizures, would be more reliably able to predict that for you. And last consideration here for invasive EEG is for us to map the brain. So whenever the seizure focus or the presumed seizure focus comes close to an eloquent area of the brain. And by eloquent area, again, I mean here's the motor area of the brain. It controls motor function on the other side of the body, so the left brain controls the right body. This is the sensory strip that controls sensation. Wernicke's area is involved in speech and understanding speech. The visual cortex is involved in sight and seeing and interpreting visual stimuli that you see, and as well as Broca's area here, which is the speech center of the brain. So whenever lesions come close to where we may be operating, it's sometimes a really good idea for an invasive evaluation so we can delineate the margins of where functional brain starts. Now, does that mean that the rest of the brain does not have any function? That's not necessarily true. The rest of the brain, we're not able to test. We don't have testing paradigms to be able to tell you what exactly that part of the brain does. Now, for the vast majority, removing those areas of the brain does not cause any visible deficits that we can see or we can detect. So when we're weighing the risks and benefits of uncontrolled seizures versus removing a certain area of the brain that does not appear to us to have a certain function, we usually pick the first option to remove that area of the brain to stop the seizure. So this becomes, again, very important as we're planning for our surgery. Now, the diagnostic operation, so what we call the invasive EEGs or the phase 2 evaluation, can be done in a couple different methods. We have two types of electrodes here. So over here we have a subdural grid electrode. It looks like a grid, and it's actually similar to the other cartoon that I showed you, where it's placed on the brain, and each one of these electrodes can record electrical activity from that portion of the brain. And there are situations where this may be the better evaluation method. Now, a grid does require open surgery, so that requires, opening of the scalp, lifting the skull, and putting this on the surface of the brain. And then the other option, lower down here, it looks like a spaghetti noodle. It's called a stereotactic EEG, and this is where we use our 3D navigation system in the operating room to pinpoint exact areas, usually deeper in the brain, that we suspect is causing the epilepsy, and we can put several of these electrodes, sometimes up to 10 or 15 of these electrodes in the brain, and it allows us the ability to go on both sides of the brain or on distant parts of the brain to be able to record seizures. So it's not, these are complementary tools. It's not that one is better all the time or the other one's better all the time. These are two different techniques that we have to record seizures with greater precision than just using the scalp recordings. Obviously, this is an operation, so there's risks involved with these operations. And then comparing the subdural grid versus the stereo EEG or the spaghetti noodle electrode, there's different situations where you consider one over the other. So if you have a very focal area of epileptogenicity, or where we think the seizures are coming from, the subdural grid may be the better option. If we need to map areas of the brain, like language areas of the brain, again, the subdural grid may be the better option. For deeper structures in the brain, actually, that do not come to the surface of the brain, the stereotactic EEG is a better evaluation option. Lastly, in situations where we have a reoperation, the stereotactic EEG may be the better option, as the covering of the brain may be quite stuck to the underlying brain, so that removing that to put in a subdural grid, a large grid, may be more dangerous. Now, what happens after surgery for invasive EEG implantation? So once this is done, so this operation usually takes most of the day, or maybe half the day, to do and your child goes to the intensive care unit for the first night, and then after that, what we actually want is we want your child to have seizures. So here's a situation again where we want seizures to occur, and that allows us to be able to say with great precision where exactly these seizures are coming from. So sometimes some children have quite frequent seizures, so we can record and get a lot of data very quickly. And other times it's necessary to decrease their anti-epileptic medication to allow them to have some of their typical seizures, so we can record seizures during this time frame. So obviously, there's at this stage there's an implant on the brain, so we want to actually minimize the number of days that your child would be in hospital with this implant in their brain. But and quite often we get the information that we need within a few days, 3 or 4 days. There are instances where these implants are in for 3 weeks or so, and we don't get enough information. But for the vast majority of times, we're able to adequately get the information that we need while this implant's in. And the second thing is the brain mapping. By electrically stimulating parts of the brain and getting the child to do certain tasks, we can try to figure out and map what areas of the brain are involved with what function. Again, this has implications for surgery. And lastly, once we gather all this data, we want to interpret this data and discuss the risks and benefits of surgery with you. So if we are confident that we can find exactly where the seizures are coming from, we can discuss the potential risks of removing this part of the brain versus the benefits of surgery, and also at that time be able to better prognosticate for you what the chances of seizure freedom are after an operation. Now, I'm going to briefly talk about palliative operations before I talk about curative operations. So palliative operations are designed to reduce the number of seizures or the intensity of seizures. So there's two main surgical options for this. So number one is a corpus callosotomy, and the corpus callosum is this part of the brain. It's the area of the brain that connects the left and right side of the brain. So there's a big traffic highway for a lot of electrical signals to pass. Now, these are usually considered for children that have what we call atonic seizures. And atonic seizures are seizures that cause a sudden loss of tone in the muscles, and the child just drops to the floor. And as you can imagine, this can be very dangerous because they can hit their head, they can break an arm or a leg. In these situations, we know a corpus callosotomy, so dividing the corpus callosum, can really help atonic seizures. Again, these are palliative options, so they're not going to stop all the seizures, but they can reduce a significant portion. The second option is a vagal nerve stimulator. So the vagal nerve is one of the nerves that attaches to the base of the brain. And from animal studies, we initially found that stimulating this nerve can actually reduce the frequency and the severity of seizures. So now this has been we've been doing this in humans in a long time, and it's a quite safe operation where we put an electrode on that specific nerve that's in the neck, and we put a pulse generator, sort of like a cardiac pacemaker, right above the chest that you can see there. And this is all tunneled and it's under the skin. And what this does is we try to figure out the right settings where this can intermittently stimulate that nerve and can try to prevent or reduce seizures. Now, the numbers that we quote is that in 50% of children, 50% or more of their seizures may be reduced. So again, this is a palliative option, not a curative option. And now this battery that stays under, so in the chest where you see right above the muscles, this battery needs to be replaced. So if this is a helpful therapy, that battery needs to be replaced somewhere between every 4 and 6 years. It kind of depends on the stimulation settings and the parameters that are used. But that's an extra operation that is required every 5 years or so. And then the other type of option for surgery is a curative operation, what we call a resective surgery, so resecting a part of the brain. And the goal of these operations are to cure seizures. So here's a side view of the brain. So if we figure out if the brain, which area of the brain is causing the seizures, and epilepsy is a disorder of the surface of the brain, the cortex, the gray matter of the brain, which is right on the surface. If we can figure out and safely remove that part of the brain, we may be able to cure the seizures. And by seizure cure, I mean the potential to even be off all anti-seizure medications. Not all the time, but sometimes we're able to completely discontinue all the medications. And here's a very, on the right of your screen is a example of what we call a hemispherectomy. So this is the most extreme of all focal resections, but actually involves removing an entire half of the brain. So now in the top left, this is what's shown here, where an entire half is removed. On the bottom right, this is how this surgery is now performed. So this is now performed, instead of actually removing that half of the brain, we disconnect that half of the brain. So it's a disconnective surgery as opposed to a removal. And it functionally achieves the same outcomes, but it doesn't require us to remove entire portions of the brain. Now, in some cases, we actually have to remove brain tissue. One of the things that we do here in UCLA is once we have enough for your diagnosis, we always get your permission to try to send some of this tissue off for research purposes. And that allows us to really develop better treatments for epilepsy and be able to better diagnose and better manage these diseases. So that's something that's very important here at UCLA for us. Now, this is a newer technique to treat seizures. So there's something called an MR-guided thermal ablation. So it involves putting fiber into a specific area of the brain that is causing the seizures and being able to heat up that tissue. And we know at a certain temperature that area of the brain will get destroyed. So we try to heat up that tissue to cause a lesion. But the beauty of this operation is that it involves a very small cut on the skin, and it's not the traditional open surgery where you get a big scar and it takes longer to recover. So these, the kids that we can do this for can usually go home a lot of times just the next day. And now this is not always an option. It depends on the type of epilepsy that your child has, but in situations where we can treat the epilepsy through this methodology, that's usually much better tolerated for the child and also the family. Now, there's a couple other technologies that are on the horizon. They're actually not really they're not ready for prime time for use for treating epilepsy in children, but there's research into high-intensity focused ultrasound. So this is even less invasive, where it actually doesn't even require a cut on the skin. So this is a way to non-invasively deliver energy to a particular location or a precise location in the brain, and by being able to destroy that part of the brain, we may be able to treat the epilepsy. There's a lot of research being done in this, but this is not ready for as a treatment option. The other technology that's also being investigated is something called a repetitive transmagnetic stimulation for epilepsy. So here again, we can be very precise and try to treat an area of the brain or shut it down using magnetic pulses, so to activate or deactivate an area of the brain. So some of the early research has shown some mixed results. In certain reports it's been very efficacious, and in some reports it's not been efficacious at all. So this is an area of active research that needs to happen for us to be able to say in the future whether this would be a viable treatment option or not for pediatric epilepsy. But again, these last two techniques, the nice thing about them is that they're non-invasive, and they don't require actual surgery or a cut on the skin. Now, one of the most important things, and an area that I'm particularly interested in as part of my duty here at UCLA, is not only the clinical aspects of taking care of patients, but it's also the research aspect to try to really advance the knowledge and try to do better for children with epilepsy. So something that I'm particularly interested in is predicting the outcomes following epilepsy surgery. So one of the most important things that parents always ask is what's the probability of seizure freedom? And the truth is, we actually don't have a crystal ball. So it's very difficult for us to be able to predict with extreme precision what the chances of seizure freedom are. So most of the time, the numbers that we use are somewhere between 50 and 80%. So if everything lines up on our previous evaluation, the chances of removing that area of the brain and causing seizure freedom is about 80%. Now, in cases where not everything lines up and not all the supporting data are pointing to the same place, maybe closer to 50%. But these are all guesses, so these are not accurate estimates, but it's somewhere in that ballpark. Now, one of the research studies that I've been involved with was specifically for tuberous sclerosis complex, and here we looked at many different centers putting their experiences of tuberous sclerosis patients together, was that we found that good seizure outcomes can be achieved in about 69% of children with tuberous sclerosis. So this gives us better ability to predict the outcome of surgery. It's only through these multi-center large studies that we'll be able to have more precise estimates. And currently, we're doing a worldwide study for hemispherectomy to try to predict the outcome of surgery through this radical operation, a hemispherectomy operation. And this is information that will also be coming in the next few years. Thank you very much. I welcome you to ask any questions on Twitter using hashtag UCLAMDChat. Thank you. So the first question is, I apologize. What are some medical advancements in treating moya-moya disease and seizures? So moya-moya disease is not usually involved in intractable epilepsy, which is the topic for this talk. So seizures can be associated with moya-moya disease, but that's a different topic. Usually we don't do epilepsy surgery for moya-moya disease. So the second question is, when should I call my doctor about my child's epilepsy? So the first time your child has a seizure, that's an important time to, sorry. That's an important time to have your child evaluated, usually at an emergency department. And then after you've seen your epileptologist, usually at that point, if your child has epilepsy, they have they've given you information about what to do when your child has a seizure. Now, specific seizures can require medical attention. So seizures lasting more than 5 minutes, or a child that has repetitive seizures without gaining consciousness. Those are both situations where it can be a medical emergency. So that requires you to again, come to the emergency room for an evaluation. So third question, how should we change our diet, sleep, or lifestyle if my child has epilepsy? So, this is, so there's two things that we don't recommend your child do while they have epilepsy. So one is swimming, because swimming can be dangerous, or being in a tub of water, because if they have a seizure, they can drown. And the second thing, I don't know how old your child is, but driving is another issue that people with epilepsy should not be driving. But in terms of that, so things that can provoke seizures are sometimes getting very little sleep can provoke seizures. Flashing lights can provoke seizures. So those are things that are known to cause epilepsy. Now, having said that, you want to make sure, you want to speak to your child and try to explain their condition to them and also try to make them live as much of a normal life as they can. So try to really integrate with their friends, and as long as they have as long as there's a plan in place, if they're, so sleeping over, if they have a seizure, is there an adult there? So those sorts of issues become very important. But as much as possible, I think one of the best things to do is to try to integrate them with other kids their age. Is there anything I can do to prevent epilepsy? No, not really. Right now, there's nothing that we know that people without epilepsy can do to try to prevent getting epilepsy. And last thing, what is the most important thing in managing my child's epilepsy? And I'd say the most important thing is to be seen by a pediatric epilepsy center. So if your child has seizures that are not controlled on medication, again, the first step is being evaluated by a center that specializes in epilepsy care. Thank you very much.